Well, I guess here we are. Good afternoon or good evening, as the case may be. Hello, CNY Nation. I'm Dr. Randy Fink talking to you live from CNY Fertility in Colorado Springs, beautiful Colorado Springs, Colorado. And we are live here at 4 o'clock p.m. straight up Mountain Time, which makes it 3 o'clock on the West Coast. 6 o'clock on the East Coast. Very happy to have you here at Fertility with Fink Friends. I'm the clinical director of IVF services here at CNY Fertility Colorado, also the medical director at the Miami Center of Excellence at CNY Fertility at the Miami Center of Excellence, a wonderful place to do monitoring if you are going through our process and you happen to live in South Florida. We've got people all over the place here. Why we've got Facebook and YouTube right here. We've got a couple of different Instagram feeds. We've got LinkedIn, and sure, I'm glad to have everybody here. Hopefully for the next hour or so to answer all your questions, thoughts, and things on your mind. Hello, Mrs. Vince. Nice to see you. And it looks like Felicia will be here in a few weeks. We're excited about that. I Care for Life. I like that name. I see Brandis, our wonderful nurse practitioner, is here on the Facebook side, or rather on the Instagram side over here, and on our CNY Instagram feed right here. So we are sure glad to have everybody. I think I may have just lost something there. Okay, good. Welcome back. So I have to tell you, one of the most common questions that I've had this week has to do with, you guys spend an awful lot of time talking about IVF. Is there anything else we do? Is there anything other than IVF that may help me to get pregnant? And the answer is yes. Now, why is it that we go right to IVF when we start talking? Well, it may not be the best choice for everybody, and that's why we do offer the choices. The reason, the studies, really show us that IVF as a modality for getting pregnant is, one, the fastest path to pregnancy, and two, is the most effective path to pregnancy. So when folks are having home intercourse, just sort of trying at home, we suspect that about 85% of couples will conceive within about 1 year of appropriately timed intercourse. Now, that assumes that the female is ovulating, and that assumes that there are sperm from the male that are swimming. And assuming those things work, 85% of the time, a couple will be pregnant generally within a year. What is that appropriate timing of intercourse? What does that actually mean? Well, so we know that on average, people will have 28-day cycles, and that's obviously, there's some variability with that. But in general, we know that, so you'll probably ovulate or release your egg around day 14. And if you release your egg on day 14, we know that sperm probably lives for about 72 hours on the inside. So day 11 through day 17 of the cycle, with day 1 being the first day of period flow, that's cycle day 1, typically intercourse every other day between day 11 and day 17. That's what we call appropriately timed intercourse, and is typically enough to get 85% of couples pregnant within 1 year. So if it doesn't happen, what happens next? What do we do? Well, there are some other options. Sometimes we help folks just with timed intercourse, because if we don't know at home when we're ovulating, and sometimes using those doggone ovulation predictor kits can be so frustrating, because maybe you miss it, maybe you don't have enough of them, maybe the hormone in the urine's a little too concentrated. They're very frustrating. They are fraught with inaccuracy. So they get hard to do. So we can help you by monitoring by ultrasound to see where your ovary is in its cycle and when you're going to produce an egg that is going to ovulate and potentially get you pregnant. So by doing that, and that we call timed intercourse, we can try to maximize the opportunity for sperm to be able to meet egg in the normal way. Sperm swims in through the vagina, it goes in through the cervix and into the uterus. That sperm swims up actually into the fallopian tube. The egg has been released by the ovary and is picked up by the fallopian tube. Sperm and egg meet inside the fallopian tube, and that creates an embryo. That embryo then floats its way down and implants inside the uterine cavity, and that's what results in pregnancy. So, good deal when it works the way it's supposed to. When we help you by timing, just with timed intercourse, we may increase the chance of you to get pregnant from, let's call it maybe 1 to 2% per cycle, to increase it maybe to 3 to 4% per cycle. That might not sound like a lot, but in fact, what we're doing is really doubling the chance for you to get pregnant. We can further do what we call OI, or ovulation induction. With ovulation induction, we typically give you an oral medication. Usually what we do in reproductive endocrinology is use a medication that's called letrozole. Many of you have used letrozole. Some people have used Clomid or clomiphene citrate in the past. And what this medication does is that it convinces the brain to make more FSH hormone. FSH is follicle stimulating hormone, which tells the ovaries to produce an egg. So certainly if you don't make an egg, so people with polycystic ovarian syndrome, for instance, may chronically not ovulate on your own. Well, we can give you a dominant egg that will likely go on to ovulate by doing this process of ovulation induction. And when we do ovulation induction and timed intercourse, we may further be able to increase the chance of sperm beating egg, going to hopefully about 5% or so. We can step that up still another notch and make it really 5 to 10% chance of pregnancy in a given cycle by doing an IUI, or an intrauterine insemination. And that's where male partner gives us sperm, or we're using banked donor sperm in some cases, and we prepare that sperm in the lab and separate out the best and the strongest swimmers, and we place those sperm inside the uterus at just the right time, so that we are getting the sperm past the cervix, we're getting it all the way into the uterus. So all they need to do is take a right or take a left and swim up into the tube to meet the egg. And once again, trying to maximize the opportunity for sperm to meet egg. So 5 to 10% chance of pregnancy there. Well, when we're doing IVF, we can give you really up to a 60% chance of pregnancy with any one embryo. So 60% per embryo, and there's some variability in that. It depends on the type of embryo, and it depends on some other factors. But if you're looking at a high double-digit percentage per embryo compared to a single-digit percentage per cycle, or per, call it menstrual cycle, odds are just simply much better with IVF. And where we are able to offer you the chance to do IVF with the financing that CNY offers and at the price point that CNY offers, for me, in my opinion, in many cases, it just makes an awful lot more sense to move to the more effective treatment, and that is IVF. Now, if you're in a place where your IVF is going to cost you, $30,000 for a single cycle, and those places are more common than not, then maybe you do a bunch of other things, a bunch of less effective things in order to try to get that pregnancy. But again, so proud to be a part of this organization where IVF is accessible to everyone. So hopefully that answers the question, what else can we do besides IVF? So let's turn towards some questions from the internet now. By the way, again, welcome Fertility with Fink and Friends. I'm Randy Fink in Colorado Springs. We are live in our CNY Nation and across international boundaries via the internet. So especially a hello to our friend Sally, who is in the Caribbean. All my friends in Miami, it's good to see everybody. Thanks for being here today. So Morgan is asking a question here on the Facebook side. Let's see if I can bring that up there. Hi, Morgan. Looking forward to doing a cycle with CNY soon. Paid before the prices went up. If you didn't know, CNY's prices did nominally go up. We are still the lowest cost IVF in the nation, but they did go up to keep up with inflation. And people did have a chance to sort of get in to that payment structure to commit to a cycle before the prices went up. And that's what Morgan did here. Still a ways out. You'll be using donor sperm to become a single mother by choice. Congratulations, Morgan. That is really just a beautiful choice to make. And we are proud of you for doing that. And some time sensitive questions about some logistics. So answer some donor sperm questions. Throw some questions up if we can answer them. We will. It's hard to give real personal advice here on a live presentation, but anything we can do. But single moms by choice are something that we feel very strongly about here at CNY. Just like same-sex couples, just like married couples or unmarried couples, and for that matter, even folks who just want to retrieve eggs. Anything that we can do to help, we are happy to do so. Is it okay, Angelina asks, to use some supplements to lose weight before doing, I guess that means before doing an embryo transfer. So certainly to the extent that you can make your body healthier, anything that you can do to be healthier is a good thing. Kind of all the rage right now is a medication that's called semaglutide, which is what's called a GLP-1 agonist. Semaglutide is Wegovy, Ozempic. The prescription medications are often not covered by insurance and are extremely expensive, but there are compounded versions of these medications that are very effective for weight loss. And the whole weight loss conversation is a different one that kind of exceeds the scope of what we have here, but it is something I do in my other practice at Cheyenne Mountain Gynecology here in Colorado Springs. You can't use that medication and many of the weight loss medications when you are trying to get pregnant. So if we're approaching the time to do an embryo transfer, we want you off those medicines. But there are other supplements, there are other weight loss things that you can do as you're getting prepared. Look who is here on the Facebook side. My dear friend Ryan. Ryan is one of our wonderful nurse anesthetists here at CNY Fertility Colorado and has agreed to join me one of these wonderful Tuesday afternoons to answer all your questions about anesthesia, because I know that that's something that concerns people, makes people anxious. If you haven't gone to sleep before for a procedure, feeling that loss of control can be very frightening, but I will tell you it's very, very safe to do, and you are in some truly blessed hands in watching every breath you take while you're asleep with us here at CNY Fertility. So Ryan, thanks for being there. We'll look forward to having you come visit with us. Deanna asks about vitamin D. Is it important? And the answer is yes, particularly because vitamin D levels are associated with success in embryo transfers. So it turns out that most of us are vitamin D deficient. So even when I was practicing gynecology in Miami and saw a whole bunch of people who were lifeguards at Miami Beach, and we get our vitamin D really from the sun, but people who were spending their days all day out in the sunshine were still vitamin D deficient. Why are we vitamin D deficient? There are a lot of proposed reasons for that, but the answer is the labs typically tell us we want a vitamin D level above a 30. The anti-aging literature tells us, and those of us that practice in those circles will say, we really want to get your vitamin D level between a 60 and an 80. That's where it's really most optimum, and so that's what we strive for. The easiest way to do that, I suggest that there is no dose of vitamin D that is useful below a level of about 5,000 units a day. So there are some vitamins that have 1,000 units. They're called IUs, international units of vitamin D, or 2,000, and they really just don't do very much. Conversely, sometimes your doc will prescribe to you, when you're really deficient, may prescribe a dose of about 50,000 units taken once a week. And the fact there is as well that our bodies just don't absorb that much vitamin D. So the best vitamin D to take is a combination, and it's a liquid. I can send you a link for this if you'd like to let me know through my Instagram, and that's at Randy Fink MD. Send me your email address, and I can send you a link for the vitamin D that I recommend, which is a liquid combination of vitamin D3 with vitamin K2. So vitamin K, what the heck is that? And why does that make a difference? They've known for generations that adding vitamin K to vitamin D increases the absorption of the vitamin D. So that's a good thing. But some wise person went out and did a study to look and see, well, what else is the vitamin D doing? Is that harming us in any way, or is it actually a good thing? And this was called the Rotterdam trial. And what they found was the use of this particular vitamin K in its liquid form decreased plaques in the coronary arteries by 50%, and also decreased cardiac death by 50%. So the day I read that study was the day I started using it, and I will recommend it to everyone. It's very, very easy to use, this liquid. It literally tastes like nothing. Now, if it were noxious and disgusting, it would be something that's very easy to remember to take, because you put a little drop of it in your mouth, and if you're about to vomit, you're going to remember what that thing tasted like, right? Well, this tastes like water. It literally tastes like nothing. So the biggest negative is that because it tastes like nothing, you may forget to use it. So you put it by your toothbrush. You wake up, you brush your teeth, and you place 5 drops. 1, 2, 3, 4, 5. That's not 5 droppers full, but rather 5 individual drops onto your tongue. That's 5,000 units a day with 50 units of vitamin K2. Again, Randy Fink MD is the Instagram handle. Send me your email address, and I'm happy to send you the link for that particular vitamin D that I recommend. Thanks so much there for that question. Let's see what else we have going on here. Looks like Nikki Baby, can I come in for IVF with the new promo? We welcome patients every single day of the week, so please pick up the phone, set up an appointment. The appointments sometimes take a little time to get with us because there is such demand for our services at this price point. Once you make that appointment, you'll have a consultation with one of our providers. We will set up a plan for you. We will check some labs and sometimes some imaging. And then we set up a call with with the nursing team that's going to be following you, which is either what's called the global travel team, if you are not local to one of our offices, or with one of our local nursing team offices. And they typically have a phone call with you, which reorients you to the process, make sure the medication gets in your hands, that the monitoring is set up. And once that's done, my gosh, then we just wait for you to have your period, because that's the trigger for us to begin. Now, some people don't get a period every month, and we have ways around that too, but that's the typical process for the way things go here around CNY. And it looks like Carly Tercio says, oh, did my transfer on 224 and got a positive beta. The crowd is going wild, ladies and gentlemen. So excited and thankful for the team here at Colorado Springs. Well, we are thankful for you. All the CNY Fertility family stands up and cheers for every single positive pregnancy test that we get. And so if you have not yet been one of them, you will be. And we are so excited to have you as a part of our group. So congratulations, Carly. That's really fantastic. Oh, and here is it looks like the Joneses also had a transfer on 225 and another positive pregnancy test. Boy, we are getting all kinds of good news here today. That makes me so happy. Abby Zimmerman says going in for my transfer on March the 13th. What about HCG boosters? And that's a very good question. HCG boosters are a part of our level 3 immune protocol. HCG is the pregnancy hormone. And what it does in the body is that it functions like the luteinizing hormone or LH hormone that our bodies make. And these hormones are basically the communication device between the brain and the stuff down there that tells our reproductive system what to do. So, what the HCG boosters do is ultimately they are metabolized to increase your progesterone levels. What is progesterone? Pro sounds like positive. Gestation's pregnancy, right? Progesterone is the hormone that will maintain the pregnancy. So when we get you pregnant through artificial reproductive or assisted reproductive technologies, we will give you extra progesterone because your own body really won't start making it in IVF terms until after about 9 weeks of pregnancy. And by 9 weeks, the placenta takes over making all that progesterone. But until then, we're going to give you extra progesterone. The HCG boosters are metabolized to make progesterone in your body. If you are doing a natural or a modified natural embryo, frozen embryo transfer cycle, I strongly recommend the HCG boosters. They are very beneficial in a natural or a modified natural cycle. In a medicated cycle, they certainly can't hurt because more progesterone is better. We're already giving you progesterone in oil, the injections, which is the most important form of progesterone, and oftentimes the vaginal progesterone as well. So I just had a conversation today with a patient who was on for a variety of reasons, on some extremely high doses of progesterone, but she was also taking a lot of high doses of oral progesterone. So the progesterone that we use the brand name is called Prometrium, or it's oral micronized progesterone, or it's a natural form of progesterone when taken orally. Natural progesterone has a sedative effect. So it works in the body when taken orally on the same pathways in the brain that many of the tranquilizers do. So that's why we tell you to take it at night when you go to bed, because it has a natural sedative effect. But if you're taking an awful lot of it, it may leave you feeling not so good, like extra sleepy during the day, or sometimes just stupefied from taking it a little too much. So we try to avoid that oral progesterone when we can. Usually we'll use it vaginally, or again, the most important progesterone is the progesterone in oil injection, which of course is everyone's least favorite thing to do because it's a progesterone and oil injection, but it doesn't feel very good. But there are ways around that. There are some helpful hints we have. And certainly reach out to your friends here in the community, because one of the things that I am fond of saying on these broadcasts is that the fertility community who follows us at CNY is really a tremendous wonderful resource. There are lots of very friendly people who are willing to share their own experiences and to help guide you with yours when we can't be there. So thanks for that question about the HCG boosters. Let's see what else. We've got a lot of folks watching us here, and I really appreciate you being here. Looks like Fringy Tango says, who do we recommend PGT for? So what is that PGT testing? We've talked about this before, but I do want to mention it here because it's an important thing that comes up. I deal with it really every single day with folks who may have a misunderstanding about really what the PGT is and how it might help us. PGT is pre-implantation genetic testing. And the most common we use is PGTA, which is pre-implantation genetic testing for aneuploidy. What does aneuploidy mean? It means for abnormal chromosomes. Trisomy 21, Down syndrome, typical, every type of abnormal chromosome that they can find on PGT testing. I think the best use of PGT is for folks who have, well, first case, recurrent pregnancy loss. So in the case of recurrent pregnancy loss, the most common reason that people will have a miscarriage is due to a chromosomal issue with the pregnancy itself. So if we can screen out those embryos that have chromosomal problems, we may be able to decrease the incidence of miscarriage. So PGT testing is very useful in that group. Secondly, it's useful for those who have a large number of embryos. Let's say that you got yourself 15 embryos from your IVF. Well, so first thing we have to do is in order to do PGT testing, we have to grow those embryos to the blastocyst stage. The blastocyst stage is typically day 5, sometimes day 6, sometimes day 7. So the first trick is that nature is going to help us select out which of those embryos are more likely to get you a baby. So some of them won't survive. So nature is going to help us. The ones that do survive to the blast stage are then biopsied. The portion of the embryo that's being biopsied is the what's called the trophectoderm, and that's the portion of the embryo that becomes the placenta. They can take a little laser biopsy of that placental tissue and send that off. So now let's say we've gone from 15 of your embryos down to, let's say 10 of them made it to blast. Well, that's still 10 embryos. That's still potentially a lot of transfers to have to do to find the ones that may be normal for you. So then we biopsy those 10 embryos, and maybe we find that 5 of them, for example, are chromosomally normal. And of those 5, now we know these are the ones that we'll start with for your transfer. That, I think, is the best use of PGT. Where I think PGTA falls down and where people don't have a good understanding of it is that I'll see folks who will say, well, I'm going to get 1 embryo here or 2 embryos from my retrieval, but I want to have a normal baby, so I'm going to do that PGT testing to make sure that I have a normal baby. And I always say, okay, how many of the folks watching don't want to have a normal baby? Pretty much everybody wants a normal baby. PGT is not designed to tell you if you are going to have a normal baby, because in most cases, abnormal embryos in IVF simply don't implant. So you never get a positive pregnancy test. Now you can, and sometimes it does happen, and it's I think one of the cruelest things in the world that folks undergo IVF, they get pregnant, and then they have a miscarriage, and that miscarriage still can be because of embryo factors or genetic chromosomal issues. But more often than not, an abnormal embryo simply will not get you a positive pregnancy test. So it's not that you have to do PGT testing because you want to have a normal baby. Everyone wants to have a normal baby. But it's not that, oh, well, given your age, let's say you're 39 or 40 years old, and you've been told that, well, if I'm over 35, that's considered advanced maternal age, and I'm at risk for having a baby with Down syndrome. So I need to do that testing to make sure that I don't have a baby with a chromosomal problem. Really not the use of PGTA. Now, there are other types of PGT. We can check for specific mutations. If we know that you and your partner are both carriers of the same type of mutation, such as cystic fibrosis. If you're both cystic fibrosis carriers, we know that gives you a 1 in 4 chance of having an affected baby. So by using what's called PGT-M, we are able to separate out the embryos that are affected by cystic fibrosis so that you don't have a baby affected with your genetic disease. I hope that answers the question about Frenchy Tango. I just like your name. I could just kind of keep saying that all afternoon long. So let's see what else we have here. I think we're going to go back to Morgan, who asked a question over here about sperm donors. Let's see here. For known donors, does CNY require the 6-month quarantine process, or can the donor simply make the directed donation with testing within 7 days? That's a good question, and that's something that I would refer to our donor team. However, I believe it is an FDA requirement that if you're using a known donor who is not an intimate partner, there are some infectious disease clearances that are needed, and that process can sometimes take 6 months to determine. So Morgan, I wish I had more specifics on that, but that's kind of a donor team question for us. If you already have some eggs frozen, but then do another full cycle, can the initial eggs be added to the batch retrieved and the fertilization happen at the same time? The answer to that is yes. So basically what you're doing is a frozen egg backup. If they were your eggs from a prior retrieval, they can thaw and fertilize at the same time. And I believe there is some cost savings to doing that because the lab is going to be fertilizing your eggs anyway from the time of retrieval. Let's see what else we have here. There's a question about CMV, and I do want to mention CMV. Can a CMV negative, well, I think it cut off there, but let's talk a little bit about CMV and what that means. CMV is the cytomegalovirus, CMV. Many of us, in fact, I would say that most of us as adults have been exposed to CMV. And when you had it, it may have been a flu-like illness, a respiratory illness. It may not have stood out as anything other than kind of just simply that. But when CMV is contracted during pregnancy, it can wreak havoc on a pregnancy, and in fact is the most common cause of congenital deafness. So when someone is going to be using donor sperm, we will typically test them for CMV. Because if you are CMV positive, then that means you have been exposed to CMV at some point during your life. It doesn't really matter about the sperm donor if they're positive or negative, because once you've had it, you are already CMV immune. If, however, you are CMV negative, then we want to be able to use a donor sperm that is also CMV negative, because there is a theoretical risk that the sperm itself can contain the cytomegalovirus, which can then infect the pregnancy from the time of fertilization. It's a theoretical risk, but if you are CMV negative, we recommend that you get CMV negative sperm. And that's something that the sperm banks will all sort of advertise as one of the criteria by which you can select your sperm. If you are CMV positive, then CMV positive, CMV negative, it doesn't, it will not matter. But now I say it's a theoretical risk, and I have to tell you that, we don't test our sexual partners in nature. We don't find a partner and then say, I love you, I want to be with you for the rest of my life. But first, let's see if you've had cytomegalovirus. Not a conversation that you hear very often. So in nature, we kind of procreate the way we procreate, and we don't worry so much about CMV. But given that it's something that we can test for and that it's a potential risk we can avoid, we do recommend you do it. And for that same reason, we recommend that folks do the genetic carrier screening tests, because there are about 500 different diseases that we've been able to recognize and know their locations on the chromosome. It is not at all uncommon to find that you are a carrier of one of those diseases. So, like I said, I think a little earlier, then we test your partner, who may very well also be a carrier. If you're both carriers of the same thing, what did I say? 1 in 4 chance of having an affected baby. So we can prevent that from happening. Now, what are the odds that you're both going to be a carrier of the same thing? Frankly, the odds are pretty low, but it's your baby. Do you want to take that risk? I mean, I certainly don't, especially when it's so easy to test for these things. Now, many of these diseases, even I have never heard of. They are sort of rare diseases, things that are called inborn errors of metabolism. They are sometimes very complex diseases. Some of them are more common, but many of them are things that you won't have heard of, just like I haven't either. But we can prevent them. And if we can prevent them, by God, we should be preventing them. So that's my 2 cents worth on that. Let's see what we have here. So Felicia says that she had a failed second transfer, and I'm sorry to hear that. It is a frustrating roller coaster to ride, my friend. It really is. A modified natural cycle, I think, is definitely something that we should think about. In a medicated cycle, we give you 6 to 8 days of estrogen, followed by typically 6.5 days of progesterone, followed by your transfer. That medicated cycle thing has been in place since IVF was invented. This is what they have done kind of since the dawn of IVF time, because we can control all the different variables with that. So if we can control it, it seems like that's a good idea. There isn't so much that's natural about IVF. And so that was kind of the argument against doing anything naturally. Well, in a natural cycle, and if you had asked me this question a year ago, I would have told you, well, there's really not a big difference. No significant difference in terms of outcomes with a natural versus a medicated cycle. But now we know that that's actually probably not true, that a modified natural cycle likely has a little higher pregnancy rate. It has a little lower miscarriage rate, and it certainly has a lower risk for certain types of pregnancy complications that happen later on down the line, specifically blood pressure complications in the pregnancy. So the modified natural is where your ovary makes an egg like it would any other month that you're not doing a fertility treatment. If you're one of the people who doesn't ovulate, then we can give you letrozole for ovulation induction, get you to make that follicle, to make that egg, which as it grows in the ovary makes some estrogen. Estrogen thickens up your lining. You're making your own estrogen. You don't need to be using all the extra estrogen. Then, when that egg or when that follicle is of sufficient size, we can trigger your ovulation when it's mature. That causes you to release the egg in a predictable fashion, which starts the clock on when you're going to do your embryo transfer. And once your ovary releases that egg, the little estrogen making apparatus becomes a progesterone factory. And that progesterone is where the magic lies. When you're making your own progesterone, and we still give you more because, like I said before, you need a fair amount of progesterone, kind of a lot of progesterone in that early part of pregnancy. You're making your own, and that seems to be where the advantage is. So if you have the opportunity, Felicia, and you'd like to talk to us more about doing a natural or a modified natural cycle, I think that that's a great idea. It's one of my more favorite things to do because I like seeing the outcomes. So, my friend Lauren in Florida is ready for transfer. I'm so happy for Lauren because we were able to eke out a nice little egg that fertilized and that made us an embryo. We have an embryo sitting back in the other room, waiting for you and crying for its mother. Lauren, please come get your baby. Can't wait to see you pregnant, my friend. Uh, oh, Mama Bear of Five. Thanks for the amazing things that our team does. Thank you for that feedback. So, Buddha B asks, can you talk about what causes a blighted ovum? And that's a great question. A blighted ovum is a type of miscarriage that we see. And usually, the way it presents is that there's a sac in the uterus that is the pregnancy, but usually it has no what we call fetal pole. So, in technical terms, what's happening there is that you've created a placenta, but there's no baby. A placenta with no baby, it can't go anywhere, and there's nothing for it to do because there's no baby for it to develop. This can happen for a number of reasons, but one of the things is that in the embryo, if there's a problem with the portion that's called the inner cell mass, that will result in a blighted ovum. So it's basically a normal, or maybe even not normal, placental device or placental tissue in the absence of the baby itself. That's what a blighted ovum is. A very frustrating thing to see, but it decrees that there was a genetic problem with the embryo. So this is always going to be an embryo factor and not a factor that's related to mom's ability to carry. And that's an important distinction because when we look at folks who've had miscarriages, we really want to try to figure out, where is this coming from? Was this an issue of mom's blood? Was this mom's ability to carry, or was this an embryo factor? Could it have been a sperm factor? Could it have been a hormonal factor? These are the things that we try to sort out so that you can walk away with a baby. Buddha B, a blighted ovum is a crappy thing to happen, just like any pregnancy loss. So if that was part of your story, sorry to hear that. And I'm certainly hoping that there are happier times ahead. Mama Bear of Five asks about success rate of postmenopausal embryo transfers with donor embryos. So this reminds me of a couple of things I want to talk about. Embryo donation is where someone has made eggs, has retrieved eggs, has fertilized those eggs, and has made embryos and has decided that they no longer wish to use the embryos. Now, CNY does have an embryo donor list. There is a fairly long wait list for embryo donors. However, what we can do in the absence of waiting for that embryo donation list to clear is to let folks make their own embryos, even if you're using donor egg and donor sperm. Because if you do that, you're probably going to spend about the same thing as you will on donor embryos that are already made. So you make your own embryos. You can use donor egg and donor sperm. You can use donor egg and partner sperm, or however that's going to shake out. But that allows you to make your own embryos, which we can then place back inside of you. Now, can we do that after you're in menopause all day long? We can. So, if you're menopausal, which means that basically your ovaries have run out of the eggs that we're going to be using to fertilize. So the egg source has to come from someplace else. You're not making your own hormone anymore because we don't have any more eggs that are inside the ovaries. Well, in that situation, obviously we can't use your eggs, but we can still make the body ready to be pregnant kind of at any point. The oldest I've seen stories of a 75-year-old woman who got pregnant with using donor embryos. Um, it begs the question, do you want to be 75 and getting pregnant? Do you want to be 77 years old with a 2-year-old at home? I'm going to say no personally, but others may have a different feeling. Those who are earlier on in menopause, it makes all the sense in the world. Yes, we can make your body pregnant simply by restoring some of the hormones that your body is lacking as a result of the menopause. So, Mama Bear of 5, all the best to you. I can see a very tiny picture on your profile there. It looks like a beautiful family. And if we can help you add to it, um, that's a good thing. Hey, my dear friend Angie, my longtime patient from Miami, was here in Colorado Springs last week. We did a wonderful retrieval. She did very well with her IVF, and she had a fresh embryo transfer just over the weekend. And she's asking the question, is it normal that I don't feel anything different? And the answer to that is that's completely normal. I do not expect you to feel anything different to be able to say one way or the other whether your embryo implanted or not. Now, once you start to get pregnant and your HCG hormone level starts to go up, you're going to start to feel different. Typically, the first thing that people feel as the earliest sign of pregnancy is changes in the breast. Your breasts start to get sore. They start to get bigger. You start to retain water. That's oftentimes the first thing that people feel. The bloating, it tends to sometimes get worse. So certainly for those who have missed a period and are starting to get sore breasts, I would say it's time to do a pregnancy test. So I would not expect a few days after a transfer to feel anything different at all, but those different feelings will come, my friend, of that, I can assure you. Well, let's see. What else have we here? It looks like Jers is asking, at what facility are you a physician at? Well, I'm at CNY Fertility here in Colorado Springs. We have wonderful staff at all of our locations, which would be Syracuse, Buffalo, Albany. We have a monitoring center in Rochester. We have monitoring now in Sarasota, which will, in theory, become live as a full-service IVF center in the summertime. And we have a monitoring center in Miami as well, and also Atlanta. So hopefully we are close enough that we can help. It's 47 minutes past the hour. We're going to keep going for maybe another 10 or 12 minutes or so here on Fertility with Fink and Friends. Does a hydrosalpinx always mean that you have fluid in your tubes? Well, by definition, hydro means fluid, salpinx means tube. So typically what happens with a hydrosalpinx, and I've demonstrated this before, but I'm going to do it again here just because I want everyone to know what my uterus looks like, and it's this. This was a gift to me maybe about 10 or 12 years ago from a wonderful patient in Miami, and I just want you to know it still stays with me here, a smiling uterus, and that's a good thing. So here's a fallopian tube, right? And the ovary sticks off the fallopian tube. It sits sort of down here or so and is connected by some ligaments and a blood supply that comes in from here. But what happens, ovary releases the egg goes into the tube. We talked about the sperm swimming in this way and going into the tube, and the ovary, or rather the egg and the sperm meeting up together here in the tube. Well, if there's a blockage, let's say over here in the tube, and maybe a bit of blockage in here, then what happens is that this tube can fill with an inflammatory type fluid. Now, there's usually some room for sperm to be able to get through here, but the presence of the fluid in that fallopian tube signifies that there is damage in that tube. If the tube is blocked on this end, there's no place for that fluid to go. If the tube is blocked on this end, there's no way for the egg to go on the inside. But the presence of the fluid that's in this tube, also called a hydrosalpinx, can cause that fluid to work its way back inside the uterus. And if the fluid is going back into the uterus is no longer smiling. No, the embryo that's in there, that fluid can be toxic to the embryo. So for folks who have fluid that's in the fallopian tube, we recommend removing that fallopian tube because it will prevent you, in all probability, prevent you from becoming pregnant. Well, let's see what else we have here. Let's try to go back over to the Facebook side here. Let's see. Anna Marie says, what's the best way of doing a fresh cycle if you're doing reciprocal IVF in both and both partner cycles are not closest to one another? That's a very good question. So reciprocal IVF is where in a same-sex female couple, we take an egg from one partner, we have sperm from another source to fertilize those eggs and create embryos, and then the embryo then goes into the other partner, who will then be the gestational carrier, or the one who will carry that pregnancy with the egg of her partner. That's reciprocal IVF, and I think it's really probably one of the coolest things that we can do. So the question is, well, how do you coordinate people's cycles? I will tell you that it is difficult to do logistically, but basically what we'll do is place both members of the couple typically on birth control to coordinate their cycle. So if we give you some estrogen and some progesterone, then that will kind of keep your cycles. We can regulate cycles. We can have you so that you're both sort of starting a period on the same day. And that's the way that logistically we try to get two people on cycle together for a fresh transfer after reciprocal IVF. Hopefully that answers the question there. Here's a question from Erica. Hi, Erica. Have we seen any difference in women who use Clomid instead of letrozole? And is there a difference in women who use Menopur rather than HCG-LH? Erica gives us some information here. She's 42 years young. She has a diminished ovarian reserve at 0.15, and the FSH level is 22. And if that's an early cycle FSH, it suggests we're really fighting an uphill battle. Why use letrozole or Clomid if it raises FSH? Slow responder. What should we do? Well, so these are both methods of recruiting extra eggs. And the way that works is by blocking estrogen levels. And when the estrogen level is blocked, that causes the brain to make more FSH, to increase the FSH in order to try to make eggs. So in your case, Erica, what's happening there is that your brain is already looking for eggs. And because it's looking for eggs, the FSH level is high. It's trying to make you more eggs. So the problem is not that a high FSH is preventing you from being pregnant. It's rather telling us that your body is looking for a diminishing supply of eggs. So it suggests, really we do have an uphill battle in that situation. And we typically use more letrozole in this practice than clomiphene because of the way it works. There are some little shades of difference in the way it blocks estrogen. Clomiphene often will have a negative effect on the lining of the uterus, whereas letrozole does not. Letrozole typically is a little better tolerated because of the way it works. There are some protocols that I will use for those with a diminished ovarian reserve that will use Clomid for the entire cycle along with some injectables. And that's probably something, Erica, that I would suggest for you in that situation. So hopefully that helps. We've got Amara here. Hey, Amara, nice to Nice to hear from you. And you got your cool green glasses on in that picture. I support the use of colored eyeglasses, by the way, if you couldn't tell. What are your thoughts on intraovarian PRP for lackluster egg retrieval results and repeated implantation failure? So, intraovarian PRP is designed to improve the ovary's ability to respond to the stimulation medication and hopefully to be able to repair some of the age damaged DNA and to improve pregnancy outcomes. I will tell you that, the data, the real solid scientific evidence on intraovarian PRP, the data is sparse, but we use it a fair amount here at CNY. It's an easy solution to do that may just make some difference. And I have seen it really do kind of miraculous things. So I feel pretty strongly about it. PRP is platelet rich plasma, and that's where we take a tube of your blood and separate out your body's healing components, your tissue factors, and we can place it directly back inside of you in this situation. In the ovaries. So hopefully that will help you there with that. Let's see. Is there, once a pregnancy is confirmed, is it safe to stay on low-dose aspirin and Lovenox? So Lovenox, I would say we would want you to stay on in certain circumstances, but not all circumstances. Because Lovenox is a blood thinner that can increase bleeding complications, there's a special group of people, or what scientifically we would call a narrow cohort, for whom the Lovenox will be useful and will be helpful. The baby aspirin, I would say, yes, for sure, there's little harm to staying on the baby aspirin. And in fact, in folks who have had a pregnancy history that was scarred by blood pressure problems later on in pregnancy, the use of that baby aspirin or low-dose aspirin is really the only preventative measure we know that can help to prevent recurrent blood pressure complications later on in pregnancy. Good question there. Let's see what we have here. See if we can get one more in here. I think we've got something here. Having my first appointment in April. Oh, that's Zaza Balloons. I like that name too. What dose do we recommend? Oh, we talked about that for vitamin D, 5,000 a day. Again, please feel free to send me a message on Instagram. It's Randy Fink MD. Please follow me if you haven't. Give me your email address, and I will happily send you a link for the vitamin D3 K2 that I recommend. Well, it's 57 minutes past the hour, which means it's time to start wrapping up here. Fertility with Fink and Friends. Sure, I'm so happy that everybody was able to join me today, and I hope you'll join me every Tuesday afternoon, 4:00 p.m. Mountain Time, which means 6 o'clock on the East Coast, 3 o'clock on the West Coast. No matter what coast you're on, or no matter what island you live on, or no matter what continent you are, we still want to help you bring home a family. It's what we do. It's what we do every day. And it brings us an unspeakable amount of joy to know that we can help you in that which is most important in your lives. Thanks so much again for being here. We'll see you next week. Until then, Dr. Randy Fink from CNY Fertility, Colorado. Have a wonderful, wonderful rest of the week. God bless.